and people need to, play ball here. And they need to, there are a lot of people that don't believe a lot of this stuff. And, my answer to that is, round with me for a day if we could let you.
Be Inspired podcast. Real stories from real people. Sharing stories of love and loss, struggles and perseverance, laughter and tears, and overcoming adversity.
On this episode of Be Inspired, we're continuing our conversation with Dr. Jeff Miskoff, who was one of the frontline professionals battling COVID-19 and coronavirus in the height of the pandemic, and he's back with us to continue a conversation that we started in our previous episode. I'm Bert Barron.
And I'm Lisa Anderson.
And we welcome you to a very special Be Inspired.
Looking back, Dr. Miskoff, the tragedy of nursing homes, what would your thoughts be, God forbid there is a second wave, and let's hope there isn't, of handling that different? What do you think would happen in that case?
I mean, testing earlier, right? So I believe it took, and each nursing home may be different, each state may be different, but I believe it took some momentum to get the testing going. And finally, the residents, like my mom and her significant other, were tested on a frequent basis, weekly.
Oh, wow.
And her tests were negative all the way up until the admission test a day or two before.
Wow.
But then testing the providers as well was the other thing that happened later on. But it didn't happen initially. We were all inexperienced. Right? They were just trying to figure out what to do. And now we know kind of what to do. So I think starting with the next year, the next season, if you will, in the fall, they have to keep that up, not stop doing the testing on both the staff, employees, as well as the patients. Yeah. There's theories, move everybody out to these other places, and I'm not an expert in that. I'm an expert in taking care of the patient who ends up on the respirator or who's calling the office. It takes, multiple layers of officials and administrators to figure that out. But I think they can't let up on the testing for both the staff and the patients, and again, continue these practices that now we have a round of experience with.
Dr. Miskoff, I would love to get your take on the effectiveness of contact tracing. Now, keep in mind, somebody from New Jersey with a cell phone that gets a call that says, hey, you might have to quarantine for 2 weeks. A lot of people, I don't think, could hit the hang-up button fast enough on something like that. But it's proven that contact tracing is very effective in corralling something like this. It has a proven history. Do you see the same with coronavirus?
Yeah, I think so. I mean, again, we'll know by the next season what the data retrospectively and prospectively looked like. But yeah, I mean, you have to do it, right? There's no real explanation for not doing it, and it has been proven in other ailments to work. So I don't see any reason why we should stop. And people need to play ball here, and they need to there are a lot of people that don't believe a lot of this stuff. And, my answer to that is, round with me for a day if we could let you.
Yeah.
And see actually what had happened. Of course, now they would see a much lesser concern in the hospital system. But, people had said to me, I don't know if everybody's getting labeled as COVID. And I said, listen, when I show up at work, it doesn't matter what the diagnosis is per se. I see a person on a respirator with pneumonia. Right. I'm going to do what I know in my training to try and fix them, right? I know it's not the contact question, but definitely we have to continue to do that, and people need to do their part.
There's been a lot of different opinions from different sources. One day you hear that asymptomatic cannot pass it to others, and another day you hear that, yes, asymptomatic can pass it to others. I've heard the WHO the other day said, no, we found studies that show this. What are your thoughts on that, Dr. Miskoff? And also, I know the death rate is down. More are being diagnosed with COVID, and especially in the younger population. Yeah. But it seems that the virus itself seems to be weakening. What are your thoughts?
There are many different strains that are reported out there. Right now, there's several different strains. We don't know per se if one is more deadly than the other yet. Again, there's suggestions of that. I hope that with more and more people that have contracted it the next round, there'll be sort of some immunity or human protection, if you will. But it's still too early to say. We haven't had two 2 rounds of this illness yet. So there's just too many questions to honestly answer the question, to be honest. But I do think that, over time, with the treatments getting figured out, we'll still have less severe people coming in and we'll be able to treat them better. The thing is that when they first presented, it was so massive that part of the death rate may have just been from the volume coming in and lack of enough staff at one moment to care for them as they hired more and more, and they figured that out and triaged. When you get numbers, and New York City got numbers worse than us.
Yeah.
I mean, I spoke to one doc at one of the major centers in the midst of all this, and they had over 200 COVID patients, respiratory failure, severe, where we may have had 70 or 80 on respirators. They were doubling or even tripling that in some places. How can you possibly manage that? Even if you have enough respirators, it's still a new thing, and these patients were extremely ill, and some of the classic traditional treatments that we gave for patients with respiratory failure and acute respiratory distress syndrome just didn't seem to work. It was just too many patients at once, too early on, with too little knowledge.
Doctor, it seems like the potential severity of a recurrence depends upon us. If we wear the face coverings and practice the social distancing and the hand washing, I can't recall ever washing my hands so much in the last couple of months and what we've done to this point. It's really on us. It's our habits that will determine what the next 6 months or 12 months are going to look like. Is that right?
Yeah, and are the asymptomatic carriers, as the WHO may be suggesting, really not contagious? I'm going to assume they are right now, just because we saw such a massive amount of patients coming in, or the patient themselves, the person themselves, didn't recognize the symptom. So what's labeled as asymptomatic was just a little bellyache, or maybe I had a little headache, or a slight sore throat. And was that allergies? Who knows for sure? Right. That's why it's important to, contact your clinician and get that early expertise, especially in those who have treated a lot of these patients and understand some of those early symptoms that one may label as asymptomatic. And when you really probe, wasn't so. And there was definitely, at least I'm guilty of it, when so many massive patients were coming in, we're taking so many histories on these patients. When you have half the volume, your history tends to be a little bit better. Yeah. So we may have missed a couple early symptoms. I may have, candidly, not asked all the best questions immediately when you're under stress, mentally, physically. As you said, we were wearing 12-hour-a-day, 9-hour-a-day masks and shields. That first couple weeks, you get a little dizzy. You start to wonder, am I even hurting myself a little bit with this on? But we didn't have a choice. We did what we had to do. But there's definitely something to that.
Yeah, and it's, again, thank you for what you and your staff and all the first responders have done for us, because you got hit so fast. We all got hit so fast. We didn't, one minute they're talking about the virus, and the next day, literally, we're told we have to quarantine. And so many. What would you say to your patients and to others? Because I still have friends who are scared to go to the doctor. They're putting off doctor visits. And what do you think's happening to the population because of the fact that they've neglected regular testing so far?
I mean, a colleague of mine said early on, we don't want to have such blinders on that we're just looking for COVID and we're missing the obvious on other conditions that are right in front of us, right? And again, a lot of those patients just stayed out of the hospitals and got sick at home, and maybe many of them died, and we don't even know those numbers at this point in time. There's certainly, again, concern to be worried about catching the virus, but at the same time, as we spoke about before, there's a calculated risk, and staying in touch with your providers, knowing what the statistics are in your community, in your counties, and sort of figuring out what you're willing to take as a calculated risk when those numbers are extremely low. One thing you don't want to do is stay out of the doc's office or your provider's office and miss a coronary lesion, and you needed a cardiac cath, and you just didn't go in for it. So we would encourage patients to reach out. Most practices and clinicians are doing video and medicine visits to at least screen them. And sometimes I feel like it's the best thing to do first, because you kind of get the whole chart together and all that data that you really need, and then you can call them back or bring them in a week. But there are ways of getting in communication with these clinicians. But if you feel sick, if you have concerns, you should still follow the standard of cares in regards to all other parts of the body, your colonoscopies, your mammograms, all that stuff needs to be done, because you don't want to be scared of a virus that is at lower levels right now and then die of another condition that could have easily been prevented.
True. Yeah.
The thinking early on, Dr. Miskoff, at the height of this pandemic, was the longer the person was on some sort of breathing apparatus, the less their chance of survival. Does that still hold true? If someone is on a respirator or a ventilator, the more time they spend, the less likelihood they'll recover?
I think so. I mean, there's some data on that in other conditions. Each day that you spend on the ventilator is an increase in mortality risk, or a secondary infection is really what the main concern is, like with Mom. Now, Mom, developed that staph infection from the day she went on the respirator. It was already brewing in her lung. But yes, I mean, each day that you spend on a respirator is a risk for more procedures, complications of these procedures, and just the respirator itself, secondary pneumonias and infections is really what our main concern as critical care docs is. So the quicker you can get them off, which wasn't easy, and that was part of the problem, and figuring out protocols of how to have them on these high-level drips and sedatives, but still try and oxygenate them, get their oxygen levels to a reasonable level where you don't have a cardiac arrest.
What would you say, Dr. Miskoff, in terms of nutrition, aside from the medicine that you take for it? But I know a lot of folks said zinc helps, vitamin C.
I'm a big proponent. No data with COVID officially out, although there are studies that are happening with high-dose vitamin C intravenous in China and
Right.
Italy, and even in New York State.
Yeah.
Zinc was sort of put into the cocktail with hydroxychloroquine, azithromycin in that early treatment. There is some evidence that it does suppress viral replication. But when it depends on which expert you speak to, and the docs taking care of the most severe patients may have a different opinion than the ones on the outside world, the outpatient world, that are getting them with very mild symptoms. But if taken at the right doses, whatever that is, that's a whole other segment.
Yeah.
I do believe that they can be taken safely with possible benefit, but no definitive argument yet for COVID-19. And again, how many people are studying vitamin C at 1,000 milligrams versus 8,000 milligrams outpatient in a pill form versus, these severe patients that are in the ICUs? And does it help once you give it to the severe patient, or do you really need to load up on D, zinc, selenium, et cetera, and we can go on and on about different ideas that are out there and different anecdotes. Nebulization is another one, a whole thing on that, where maybe inhaled steroids are helping. Decadron from the British study, dexamethasone, which is a steroid, was the only drug right now definitively that reduced mortality or death rates in COVID patients. So how do you prescribe that, and at what dose earlier on in the outpatient setting? And that's the stuff that we have to figure out by next round, or hopefully that is it.
Yeah.
When we come back on Be Inspired, we'll conclude our conversation with Dr. Jeff Miskoff. Stay right there.
Moving is difficult. At Lowe's, it doesn't have to be. For all of your residential and commercial moving needs, contact 732-775-4118 or get a free FaceTime estimate. Lowe's, proudly serving New Jersey for over 96 years. IgA Nephropathy Foundation of America is a patient-centric organization dedicated to finding a cure and better treatment options for IgA kidney disease. If you or someone you know was recently diagnosed, or to donate, please visit IGAN.org. In this new day and age of online meetings and presentations, you need the best team at the ready. Whether broadcasting your Zoom meetings to Facebook Live or live streaming a fundraiser event, SIRREEL Streaming Services, with over 10 years of experience, can add confidence to your next live stream event. Call or text 646-498-8888 or visit sir-reel.com. Feeling stuck with your health goals? Michelle Weber Integrated Fitness and Lifestyle Design specializes in integrating simple daily routines to get you moving towards strengthening your core and boosting immunity and resiliency. With over 15 years experience, let Michelle's team help you reach your fitness and lifestyle goals by visiting michelleweber.com or on Facebook at Michelle Weber Lifestyle.
But I think the thing people need to keep in mind, Doctor, and to me it's just such an uplifting moment when someone beats COVID and they're being discharged from the hospital and there's cheering and clapping and celebrating. The thing to keep in mind is that a vast, vast majority of people will beat this, right, and will recover from it.
That's right. That's probably the most inspiring thing about it. Is that, yes, I had the first patient, a doc younger than me. He got out of there. I was grateful. He was, I'm sure, very grateful. But yet then Mom, I couldn't save, who was, had had her 75th birthday during this, when she was diagnosed and ultimately passed. So, yeah.
Yeah, that's tough. I've heard CPAP machines are now being used with better results for some patients as opposed to respirators.
Comments
you
on
done
that?
that?
Yeah, so initially we were told not to use nebulizers on patients in the hospital, and even to date, many systems are saying that because the fear is that when they use these nebulizers, the aerosolization of the COVID around the room and then the risk to other providers coming in. I have mixed feelings about that because, again, we're hearing anecdotes from earlier treatments outpatient, and yet, you're sort of limited to using that stuff in the hospital patient. CPAPs and BiPAPs are non-invasive forms of ventilation. Again, initially we were told not to use them because it could aerosolize the COVID-19 respirator droplets around the room and put others at risk. But yet, as time went on, it loosened up a bit, and we are utilizing some of those apparatus to bridge them maybe back to just regular oxygen, or a decent percentage of them fail. The majority of patients will make it. The ones that get hospitalized, it's still a significant amount of mortality throughout the country. Some states different than others, some probably based on populace. But it's worth a try, I guess, is the answer, until we have more evidence. Sometimes you just can't use it because they're already getting some sedatives. They have to have some mental status. There are some nuances that go along with using PAP machines in general. But in my opinion, it is worth a try in a select population of patients that can tolerate it.
Okay.
And we're still at the point, if someone feels they're symptomatic, to not just show up at a doctor's office, right? You still want people to call and prepare for someone who may be positive upon arriving. So it's not just show up. You don't want to give a warning that you're going to be going to a doctor, right?
Correct, Bert. In most offices, I think all pretty much are doing screening. What the doctor considers, or the nurse practitioner or PA considers a screen versus a back person who's just calling them quickly to get the information may be a little bit different. That's why I still feel like the televideo, telemed visit is appropriate day one, and then bring them back in a week once the clinician has had a chance to do their own secondary screening, another level of protection, if you will. And then there's the COVID patients that were 2 months ago that want to come in, and we at least I feel very comfortable bringing them in if it's 8, 12 weeks since their diagnosis, although I will tell you that we've seen patients that have tested positive by nasal swab on admission or at time of diagnosis, and still 5, 6, 7, even 8 weeks later, in rare cases, in the more severe cases, we see them still testing positive and not maybe breaking that till after 2 months. And even though that's sort of an unusual situation, it is possible. And then the other question is, are they still contagious at that far out? Or were I believe it was a Korean study, showed that, no, they just shed it and it's really dead virus, you don't have to worry about it so much. Please, give me more data before I feel 100% confident. I think from my standpoint, I'm not 100% going to trust any recommendation until there's multiple layers of it, and we have just a bit more experience treating this very nasty virus.
Yeah, I want to get tested, but do you have to have a prescription to do that? Do you have to have symptoms? I've heard conflicting stories, and I don't know. I was very sick a couple months ago, and weird things like pink eye. I know that's part of it as well, but I want to know, but I hear you can't really go and just walk in and say, I want to get tested.
Correct. I mean, you have to have symptoms for the most part, or direct contact with somebody who was diagnosed with COVID.
Okay.
My own niece was close to somebody who was diagnosed, and I advised that she get tested. She got tested. She was negative.
Okay.
I told her to stay away from mom and dad in the house temporarily until that result comes back. Some of the results come back a day later, and some are still coming back 5, 6, 7, 8 days later, depending on where you hear. A lot of people had that story. Myself, I felt deathly ill in November. I would swear I had COVID early. My antibodies have been negative, but then I hear about the nurse here and there, or doc, provider, where they in fact were positive by antibodies and then 3 months later negative. So even if you went and you had negative antibodies, which is the most likely thing to happen, because only about 10 to 20% of most of the populations that we looked at are actually positive for antibodies. Maybe you had the antibodies 2 months ago, 3 months ago, and now you don't. So until we have that understanding of how long the antibodies last in the masses, you could go get it tested. I would have told you a month ago to get the antibodies. Today, I don't know. And that's the thing about the disease, is that my own mind changes almost on a daily basis even today about my opinions of how to answer these questions, and they're all with a grain of salt, right? What I tell you today may be different a week from now, and I hold that disclaimer.
Oh, sure.
Well, Dr. Jeff Miskoff, thank you for joining us on Be Inspired. Just a lot of credible and real-world information.
Yeah.
We thank you for sharing that today. Again, condolences on your loss. If someone wants to contact you to meet with you, how do they do so?
Absolutely. They can contact me at Shore Pulmonary. That's 732-775-9075. We have a website, shorepulmonary.com, and we are in Monmouth and Ocean County, and absolutely available to basically field anything from respiratory. And I also am a sleep physician. We're seeing insomnia and all the stuff that goes along with that, anxiety leading to insomnia, and respiratory, just questions in patients who have recovered, or just those with questions if they've been exposed or if they had symptoms and wondered if in fact they did have it. And again, you heard my response to that, but we can still at least field the questions and concerns and give them our best advice based off of our experiences.
Very good, Doctor. Thank you again for being here. I'm Bert Barron.
And I'm Lisa Anderson.
And thank you for joining us on Be Inspired.
I'm Dr. Jeffrey Miskoff, and I am a pulmonary critical care and sleep medicine physician in the Monmouth and Ocean County area. I work with a group, Shore Pulmonary. We have 10 doctors now with our group, and again, we manage everything from respiratory ailments to sleep to COVID-19, severe patients in intensive care units. If you have any questions or concerns or need to be seen as a patient, you can contact myself or the office at shorepulmonary.com on the internet, or phone number 732-775-9075. I came on and Be Inspired, because I wanted to tell the stories of the front line and taking care of patients who, of course, did quite well, and then tell some of the stories of patients who didn't do well and what we've learned from it, and how we can learn more to hopefully take care of patients to the best of our capacity moving forward. I also wanted to tell the story of my mom, who I had taken care of during COVID-19, and unfortunately we lost her. Despite my experiences taking care of many different people, I was unable to save Mom at the end, but I did learn a lot from it, and I want to use those experiences to help others.
Next on Be Inspired.
But know what you're willing to lose your seat for. Core convictions matter. And the why of it. Why do you have that core conviction? We're in a culture now where everybody's attacking everybody. Stand down. So you got to find ways of finding common ground. I think we have to always embrace the admonitions of Martin Luther King to judge somebody by the content of their character, not the color of their skin.
Be Inspired with your hosts Bert Barron and Lisa Anderson-Puleo. Directed by Rod Weber. Created and produced by Michael R. Doyle. Co-producers Bert Barron, Lisa Anderson-Puleo, and Erwin Sternberg. Executive producers Rod Weber and Sean M. Sternberg. Editor Rebecca Gruber. Social media team Rebecca Gruber, John Franklin, and Luke Lograno. Filmed at New Beginnings Foundation, Wall Township, New Jersey. And thanks to our sponsors, Loews Moving Service, IgA Nephropathy Foundation of America, Michelle Weber Wellness, and SIRREEL Stream Services. Season 4 of Be Inspired is dedicated to the memory of Rob Izbicki, a guest of Season 2, who lost his life to cancer, and to his service to the community as a firefighter. Rob was a proud husband and loving father who cared deeply for his family and friends. Our prayers are with Rob's family during this time.